All right, so unfortunately, I do feel sorry for you guys having to listen to Dr. Schaefer and I for extra time because Dr. Alley couldn't be here. So that's first of all, my apologies. So I actually am going to give two talks, and I don't know if they probably explained that to you. I'm going to be giving a radiation talk first, and then I'm going to talk about robots. So I'm going to leave the cliffhanger talk till second. But this is a talk I gave a few months ago, actually. It's a topic that's really important to me, and I think that we probably don't value it enough. It's about radiation exposure. It's mainly important for those of us that work in the OR, including the nurses and staff that work with us in surgery, more so than the nurses that work on the floors. But I think it's important information for everybody to have. So if you bear with me, hopefully this will be educational for you from that standpoint. It's actually not the benefit of radiation. That's not why I'm here to talk about. I'm here to talk about the benefit of navigation and how that affects radiation exposure. These are my disclosures. None of them are relevant to any of the stuff I'm going to talk about. So when we see this, our first reaction is visceral, right? We see that and we want to cringe, right? This is radiation exposure to us. We should have that visceral reaction. My talk is not meant to be, hey, radiation is awesome. That's not what we're here for. What we need to be thinking about more so is the fact that it's not good. It's not great, right? We need to be educated about the ramifications of being exposed to radiation that we can't see. Radiation is like V. It's a love-hate relationship, okay? For us, intraoperative imaging is critical for spine surgeons, okay? We have to be able to do it to place our instrumentation accurately when we do procedures. But unfortunately, with that, we also hate it because with fluoroscopy, there's a risk of increased significant radiation exposure to both us, the patient, and the personnel that we work with in the OR. And then the problem is that ionizing radiation that most of us know about and we hear about unfortunately cause cell death, cell injury, and then it leads to various radiation-associated pathology. So there's problems that occurs with the fact that we have to use radiation in surgery. And there's two effects that we mainly talk about. There's a deterministic effect and a stochastic effect. Okay, the deterministic effect is the result of the radiation exposure that occur only after a certain minimum threshold has occurred. So if you look at the graph up there on the side, there's not really a problem as long as you maintain your minimum threshold to that point with regards to the radiation exposure. So the injury at this point is low enough that the cells have the ability to repair themselves and there's no long-term issues with that radiation exposure. So things that we talk about with the deterministic effect are things like cataracts, hair loss, and skin erythema. And that is not how I lost my hair, by the way. So this is not a great picture, but this is probably one of the most common things we talk about in surgery. Okay, this is a cataracts. And what happens is that actually people develop subcapsular cataracts, and it's been reported at 50% of cardiologists and 41% of nurses that work in the IR suite. So this is not trivial, okay? Although it's treatable, it's not trivial. This is a picture here, and I don't know if we can turn the lights down maybe just a little bit in here. If we can't, the other things we talk about are hair loss and skin damage. So if you have prolonged exposure to fluoroscopy, what you actually notice is there are actually changes that occur to your skin and to your hair from that standpoint. So you can get erythema and necrosis of the skin. Other things that we talk about are thyroid changes, hypertension, hyperlipidemia, reproductive organ changes, things like that. But what I'm showing here is a picture of a couple radiation IR doctors. This is a picture taken of some doctors in England. And actually, what you can't see very well, but this is the youngest one here, and these are the older guys. And actually, what happens is right below their knees here, they have no hair on their legs because that's where their leaded aprons stop. Okay, so they're hairless here, and this guy has obviously some radiation changes to his skin right above where his apron is worn. So these are real changes that occur to people that are exposed to radiation all the time. The other side of it that we talk about is stochastic effects, and stochastic is the one that we're really afraid of the most. Okay, this is where we have this ongoing increased incidence of radiation exposure, and there's no minimum here in terms of a threshold for exposure or a minimum time threshold. Okay, so what happens is over time, we continue to get exposed to the radiation. It continues to cause cell death and cell damage, and then you lead to problems, things like cancer and changes to the fetus. Okay, so this is much more serious than just the deterministic effects. Occupational risk, which is what's the most important thing to myself and to those of us that work in the OR constantly. So this is just a couple of case reports that have been put out there. Several case reports of brain tumors in the literature of over 31 physicians that work in cath labs, which is mostly where all the data comes from, and interventional cardiologists, and what they found is that 85% of tumors were located on the left side, and what they determined was that the left side was the side of the head that was actually closest to the X-ray tubes that they use in the field. So again, these are case reports. These aren't, you can't say these are level 1 evidence or anything like that, but these are unfortunately the things that we're seeing more and more of, and we're using more powerful machines as well. So the reason I talk about this is because as spine surgeons, we work in the OR suite. So this is the spine operating suite. And this is also important for our nurses and the personnel. And this is what an interventional radiology suite looks like. And I would actually argue that they look very much the same if you look at them. There's an OR table. There's a C-arm, or in the interventional radiology suite, there's a fluoroscopy device that emits fluoro. What we have in the OR is various forms of this, a C-arm or an O-arm. And so these look very much the same if you actually look at them on the onset. But these guys are very different than us, the interventional radiologists, okay? Interventional radiologists, if you actually look at what they wear from a protective equipment standpoint, they have a ton, okay? It's really unfair to us. They've got a lead shield here in front of us. They wear a leaded cap, leaded goggles. They have a thyroid shield. They've got a leaded shield underneath their gown. And in fact, there's a leaded drape sitting here underneath as well, okay? So they are fully protected within their OR suite, all right? I would argue that the OR suite that I work in was like this, okay? It's kind of a hodgepodge. We stand there, we don't have glasses on, we don't have a thyroid shield, we may or may not wear lead. We have an ancient 1950s lead shield that sits in the back of the room that we can stand behind. The nursing staff's not wearing anything either, okay? So these are, again, the same thing, but this is what we work in. Interventional radiology is more so what the interventional radiologists work in with regards to vascular. So it's very different from that standpoint. So we don't have a shield, we don't have radiation safety caps, goggles, or any of these things, which is unfortunate. So we talk about occupational risk. What does the radiation come from? Okay, there's both a direct and indirect radiation exposure. So if you look at actually a C-arm or anything that emits fluoroscopy, we have the device that emits the radiation, then we have a detector. Okay, that's why it's a C shape. And we have both direct radiation emission, which is what most of us think about, but the part we don't think about is the radiation scatter. Okay, so from the patient, from the table, or any of the devices surrounding between the emitter and the detector, actually the radiation bounces, okay, and it continues to bounce off. So actually when you're standing there, some of the radiation gets bounced off the patient's table, and then that's how you get the radiation exposure, not only just from the direct radiation itself. So there's actually a National Council of Radiation that tells you how much radiation you're supposed to have. Of course, there has to be people that have jobs to do this kind of stuff, okay? In an average year for an individual walking around that is not a healthcare individual for the public, they're supposed to be exposed to approximately 360 millirems of radiation per year, okay? 300 of that is background. So when you fly in a plane high, or you live in Colorado, which is a mile high, you get a little bit more radiation than the average person at sea level. But the bottom line is this is just based on baseline radiation exposure we get on a day-to-day level. If you have an occupation that puts you in radiation exposure, which we don't talk about as surgeons at all, this is what you're supposed to have allowed per year, okay? 5,000 to your torso, 15,000 to your eyes, 20,000 to your thyroid, and 50,000 to your hands. And these are based, again, on those deterministic and stochastic effects. Okay, what are we going to do to keep that threshold low to minimize the exposure to the individual from those things occurring? So these are the guidelines that they have published and that we try to follow from a national standpoint. This is a study that came out of England. It says increased cancer risk among surgeons in an orthopedic hospital. So what they went back is they looked over 7 years at a very small orthopedic hospital. I think this was in England, where they had very poor radiation practices, so radiation protection. Okay. In fact, during my fellowship at the Cleveland Clinic, our orthopedic surgeon would do fluoro procedures, and he would just stand in there with his hand inside the fluoro machine. It was crazy to me. It scared the heck out of me, but that was kind of, he just had this sort of like, it's not a big deal, right? And this is kind of why these guys studied this. And what they actually found is that they had a significant increase in the orthopedic surgeons developing cancer in that hospital. Okay? Yeah, exactly. Especially if you're a neurosurgeon. So what this means to them is that we actually underestimate what we do in terms of safety for protection. And this is for surgeons, but again, I'd say this for the nurses we work with and the personnel who work with us in the OR all the time. So essentially what we're showing is that there's very little and no formal education for neurosurgery or orthopedic surgeons or residents with regards to how we're supposed to protect ourselves over our lifetime. And I would argue that that's the same thing for the personnel that I work with in the OR. Does anybody know who said this? What you can't see can't hurt you? I did. So I can't find this anywhere. I try to find it because it makes sense. You know, like what you can't hear can't kill you, those kinds of things. I was like, what you can't see. So that's my statement. But it's true. You can't see radiation, and that's the problem. Okay, it can kill you, and that's the whole reason why I'm up here. So we talk about minimally invasive procedures. So minimally invasive transforaminal lumbar infusions is a spine procedure that we perform, and it's very fluoro-intensive because what you're not doing is you're not exposing the patient's entire spine to get anatomic landmarks. So a lot of it's done through the skin. but we have to rely on fluoro to do a lot of the imaging studies for us. So a TLIF is a very fluoroscopic intensive procedure. So they actually looked at this and they said, you know, how many cases do you have to do per year to actually exceed the number that we talked about that the national safety people have set up? And it's approximately 250 cases per year for a busy spine surgeon. As long as you're below that, you're going to be fine, 250 cases. And I looked at my case log last year, I did 390 cases, okay? So this is an average number, and there's lots of surgeons that do more than 250. So this is, again, my point is, once we reach that threshold, you start to get up to places where it becomes a little bit dangerous. This was an investigator award, 2013 in Spine Journal, which is one of our premier spine journals that we use in both orthopedics and neurosurgeon. And so what they essentially found was, that people had to do 2,700 lateral procedures. A lateral is, again, a procedure that we use that requires a lot of fluoroscopy through a small minimally invasive incision. But if you were to do those, you'd require 2,700 procedures to be above the threshold for it. So from that procedure itself, you have to do a lot more. Okay, there's a difference here between 250 and 2,700, right? That's very hard to reach in a year. So why do I navigate? So navigation and robotics. So I'm going to talk about robotics, but before robotics came actually stealth navigation, which is what we use a lot of in all of our ORs. So stealth is kind of one of the things I use a lot of. My colleagues use a lot of it. So why do we navigate? So that gets us to this point. What's the purpose of navigation? Well, we navigate for the patient, okay? Why? So we get better accuracy when we use stealth navigation versus fluoroscopy. There are great published papers. So using a C-arm to place pedicle screws versus using the stealth navigation system, there's probably 20, 30, 50 pages that have been published since the 80s, 90s, 2000s. The accuracy with freehand fluoroscopic screws is probably in the 80s to low 90s. If you get to stealth navigation, it's in the high 90s. Okay, that's from an accuracy standpoint. We can also perform more MIS procedures for patients. So smaller incision, less muscle tissue, less blood loss, faster recovery time, better for the patient. All right. Why do I navigate for myself? Is obviously that's selfish. Why did I go through this whole talk to show you why we navigate? Well, there's lots of reasons. First of all, accuracy. I want my pedicle screws and my interbody grafts and all of the sort of stuff I do for my patient to be accurate. That's number one. There's an auto-registration process, so I don't have to do a lot of registration for the patient. If we take a trauma patient that has unstable spines and the anatomy changes, we get that in real time. We can plan our accurate cases. Most importantly, we can reduce the radiation for myself and the OR staff, which is really important to me, and we don't wear lead. Nobody's ever seen me wear lead in my cases. And for anybody here that does lead, I see Dr. Leo shaking his head. It kills your back, it kills your neck if you're standing for 8 hours wearing heavy lead, okay? And if you can imagine what happens after 40 or 50 years, you start looking like V. So that's the most important thing. So what are our strategies to do this? Simple precautions like we've been talking about, right, to minimize the radiation exposure to our patients, to our staff, and to ourselves, okay? So how do we do this? One is time, okay, radiation time. So people love to step on the button when we have a fluoroscopic image. You have the radiation tech. Shorter, quicker bursts of radiation. Some people like to do continuous fluoro. That's a lot worse than doing intermittent spot checks, okay? So reduction of time is important for reducing radiation exposure. Distance, okay? The distance drops off significantly as you get farther and farther away, and most of you probably know this as you get 6 feet or further from a fluoroscopic device in the OR. Typically, they say the radiation exposure is close to 0. I don't believe that because I can't see it, but that's the number they give you, and the reason is it's inversely proportional to the distance. So the more you get, the farther you get away, it really drops off. So it's important to really stand farther away from the fluoro machine rather than standing next to the device if you can avoid it. Shielding, which we try to do a lot of in the OR. So we have our lead aprons, we have our thyroid shields, we have our leaded glasses, and we have those big 1950s block shields that we can use to protect us from the radiation. And then there's something called the ALARA principle, A-L-A-R-A, which is as low as reasonably achievable. And that principle essentially means that we try to minimize the dosage exposure to the patient as possible. So if you have a large patient versus a skinny patient, they'll change the dosage that the patient will get based on the metrics of the fluoro machine. So you can try to reduce that. So that's the ALARA principle. Always do the ALARA principle. So this is the navigation system that we use in the ORs, but this is one of the devices. There's multiple devices out there that you can do for this, but this is the navigation system, and this is actually what helps emit the radiation during surgeries, and we use this during our surgeries to perform our procedures that helps reduce the radiation exposure to ourselves. And this is essentially what it looks like. Now, there are multiple devices out there like this. This is a I don't know if I can play this. Maybe not. Either way. What this does is this comes in, it scans the patient and essentially creates a 3D image of the patient's anatomy. While this is occurring, we all step out of the room or step behind lead shields, and we reduce our radiation exposure. And this is what the radiation looks like. If you look at it, I call this the butterfly effect. So if you look at the device from the top, the radiation technologist will stand back here. The radiation is essentially 0 to them behind there. There's a leaded shield back here. And it's sort of worse depending on where you stand with regards to the machine itself. And this is what it looks like when we're in the OR to try to reduce our radiation exposure. So this is actually a study that I was involved in, looking at radiation. So what I did is we performed screw placement using the navigation system versus fluoroscopy. And we had a bunch of radiation badges on our torso, on our hands, and on our neck. And we measured the radiation exposure to myself after performing 4 spinal surgeries, both MIS and open with fluoro and navigation. And the blue is the radiation exposure for the open fluoroscopic images, and pink is using the navigation system. Okay, so pink is essentially non-detectable, close to 0 for me. And the blue is how much we got for 4 cases each. So you can imagine how much that adds up if you do 4 to 8 cases a week, right? Very quickly you get up there. So this was just looking at, this is a study that was published on using the navigation system. This was published by Dr. Birch, who's a great surgeon out in California. And they essentially found that the radiation exposure to the surgeon was close to undetectable in the navigation portion of the surgery. Okay, back to what I was talking about. The one thing people always ask is, well, if you're exposing yourself with the O-arm, what about the patient, right? The patient's on the table. So now you have this collimator and this detector, and you're exposing the patient to a bunch of radiation just to protect yourself. And that's a fair statement. So when we do these navigations, they actually have a spin that you do, and that's considered 1 spin, 2 spin, 3 spins, and you can set the radiation exposure to the patient's anatomy. And if you look at what these are, and in fact the devices are even better, you can actually reduce the radiation a little bit more. One scan itself is about 324 of the millirems that we talked about. So it's close to what your background radiation is for a year. That makes sense. So yeah, the patient does get that at one time, but a lot of patients get CT scans as well as part of their preoperative workup, so we try to avoid that. Does that make sense? So it almost becomes a wash/reduction in the radiation to the patient. Does that make sense? So radiation overall, so navigation to me really has a lot of benefits to doing that. Reduce the radiation exposure for myself and my OR staff and nursing staff, as well as my patients. It's really important for us to establish good safety hygiene in terms of radiation for our patients and for ourselves. Try to be smart about that. And then they have this whole campaign called Image Wisely, which is great. What they're trying to do is reduce the overall radiation exposure to our patients, both in the hospital and outside, with X-rays and things like that, to help reduce what we're trying to do to our patients, because it's not trivial to do that to our patients. So that's my first talk.